we're seeing FDG-PET used more and more to categorize the responses to the treatment of Hodgkin's disease. And the data that's coming out of the trials which have been carried out show that if you reduce treatment for patients who have a negative PET scan, you can get just as good responses in the long term as continuing with intensive treatment. And conversely, if you escalate treatment for the patients who are responding less well on an interim PET scan, you can see very good improvements in progression-free survival. But what we're also seeing in these trials is that PET is an imperfect test. In particular, we see that there is what you might think of as a false negative rate to PET scans. So some patients who have a negative interim PET scan will nonetheless go on and develop recurrent Hodgkin's disease. And the H10 trial, which tested this question in early Hodgkin's lymphoma, showed that by reducing treatment, in particular dropping involved field radiotherapy following a negative PET scan, there seemed to be a slight increase in progressions compared to the control arm who went on to have radiotherapy treatment. So what we would like to do is see if we can make FDG-PET a more discriminatory test. And one of the things that we've found is that the interim PET's accuracy is determined by two things. One is the extent of the Hodgkin's disease at presentation, and the other is the intensity of treatment that you give between the initial presentation and the interim PET. Now, if you look at how much Hodgkin's disease is present at presentation, the negative predictive value of interim PET goes down with more extensive disease. We can do that from anatomical staging, and we can do that from the International Prognostic Score. But neither of these is 100% accurate. So what we would like is some way of measuring the total burden of lymphoma and seeing whether that can better inform the interpretation of interim PET. Using total lymphoma glycolysis as a means of reflecting both the intensity of activity and the anatomical extent of the lymphoma, we think may give us a better handle on this. This abstract was an analysis of a subgroup of patients treated in the H10 trial using the baseline PET characteristics to derive a prognostic score which, in combination with the interim PET scan, was able to deliver a better prognostic model. Now, this art is in its infancy at the moment, and we don't yet have established cutoff points. The cutoffs which were used in this study were largely derived retrospectively in order to produce the best discrimination possible in the model as constructed. There is no a priori reason for choosing a particular cutoff for total lesional glycolysis. So this is something which we're in the process of constructing at the moment in order to derive better models for the management. Different prognostic groups can be identified according to, firstly, the extent of the lymphoma at presentation, and secondly, the response on the interim PET scan. Now, the major driver of outcome, if you look at the prognosis, is the interim PET response, whether it's gone FDG negative after 2 cycles of ABVD. But there's an overlay of additional prognostic information that you get which is independent of that, which is the total lesional glycolysis. So patients with a high initial tumor burden have a worse outcome, even if they have a positive PET scan, than those who don't have a high burden at presentation. Current practice is using interim PET to guide the escalation and de-escalation of therapy. I think we need to refine that, and the best way to refine that is probably going to be some form of biomarker analysis at the baseline, which will give us a means of making the interim PET more accurate. And these PET-derived measures, such as total lesional glycolysis or other measures of metabolic uptake, I think may well add valuable information in the future.